of the hip.
Good afternoon, everybody, and thank you, Vigas. It's great to get everybody here. I'm sorry it's such a crowded room for something that's important. You've heard a lot about FAI, and I know we're behind time, so I'll skip through. We've collected a lot of data right since we started hip arthroscopy, so I'm going to take you through some of the lessons that we've learnt, and a lot of those are underpinned by data that I won't show you, but that I'm happy to discuss with any of you if you want later on. I think there are simple lessons. If those of you starting out, you need to get the right patients. And one of the things we've learned is you get the imaging right, because imaging isn't just for diagnosis. You need to evaluate outcomes, and you need to be able to prognosticate. What we don't want to do is operate on the wrong patients and lose the benefits of this operation. Plain radiographs are helpful. They've been widely published on. We've found that we can get much more accuracy, particularly in terms of defining impingement on CT. So we're using cross-sectional imaging on everybody. We've published on the use of CT versus plain radiographs and found that we can pick up more of the CAM lesions and characterize them much better with CT. We use MRI scan for everybody, but it's not the ideal test in our hands for impingement, so we end up using a combination of CT for MRI and MRI scan because they give us different characteristics and help us to get this population sorted out. So plain radiographs can give you the diagnosis, but they can't reliably rule it out, particularly post-operatively if you've got a patient who hasn't got better. MRI scans routinely used. I think we're going to get to the stage over the next 5 years where it becomes very exciting in terms of cartilage sequencing and predicting which patients we should operate on. CT is very good for looking at FAI in detail, and where our research is going is towards the impact collision and really being able to dynamically model the impingement to know what you need to do surgically. I think perhaps the key thing about imaging is if you believe imaging reports or your primary care colleagues believe imaging reports, the real problem here is that these conditions aren't recognized, and unless you educate primary care physicians, educate physiotherapists, those patients won't come to you. So we've got an educational role here in terms of what we do to imaging. In terms of the learning curve, I think what Vikas was keen that I talked to you about is the surgical learning curve that we've documented very carefully. And you've already heard today that there's basic hip arthroscopy that Richard talked about at the beginning of the central compartment, then there's the peripheral compartment work, and then there's more complex work that came later. And what we've done is we've documented our journey through this work to see how long it takes us to understand these things and be able to do them. And I'll share some of that with you today. Here we go. So this is a prospective review. We've done more and more hip arthroscopies each year. We're now doing about 200 per year to give you an idea. So the numbers have escalated fairly dramatically, and all have been data-based, including a great deal of demographic and surgical data and good outcome data. There are interesting things you pick up early, which is as you get better, your traction time goes down. That doesn't necessarily mean you're a better surgeon, but it does mean the operation becomes more comfortable for all around you and more cost-effective for your hospital. So it takes about 30 cases before your time really comes down to something reasonable. You can see here our times increased again after a while, and that's when we started doing labral repairs and slightly more complex work. Complications, again, clustered very much at the left-hand side, reinforcing that sort of problem with the first 30 cases. And they're simple things, and the whole idea of coming to these symposiums is to avoid the perineal compressions, avoid the labial tears, avoid the sort of problems you occur if you get a good setup and use up-to-date equipment. Many people started hip arthroscopy using fracture tables, using the equipment available in their hospitals. The equipment that's available now makes it much easier for you. Surgical comfort, we recorded how the surgeon felt at the end of the operation, and again you see after it takes about 20 operations or so before you're really comfortable and happy resecting a CAM lesion, knowing you know where you want to get and how you want to get there. And like the central compartment, the peripheral compartment takes about 30 cases before the time for surgery becomes routine and very, very small. So we did a sequential analysis looking at our first 30 cases, then cases 60 to 90, and then cases 120 to 150 to see how we were learning, and then we've published the 2-year follow-up of those 3 cohorts. What you'll see is that the diagnostics changed over time because this was the time period where we started to recognize FAI and weren't just treating labral tears. It's fascinating now if you can pin down the surgeons who publish series of thousands of labral tears who still don't recognize FAI. There is definitely a quandary out there in the literature. Less loose bodies because I think they were the things we were dealing with to begin with, and they became a smaller proportion of our practice. Less osteoarthritis as we started to recognize it better on the imaging, and fewer miscellaneous cases because we got better essentially recognizing and characterizing the pathologies first. The time decreased fairly dramatically as we went through our learning curve. This starts off as a fairly lengthy operation and becomes a relatively quick operation. It's still nothing like a knee arthroscopy in terms of the number you can do on a list, of course, which is a problem for some of you and particularly for your hospital administrators. The peripheral compartment, again, simples up, starts off really complicated. You wonder if you're ever going to find it, and then it becomes much, much easier over time. Still some reoperations, which is something we have to eradicate, and good improvement in non-arthritic hip scores and good satisfaction, particularly once the FAI cohort came in, because they're the ones who seem to do best. So you can still get it wrong, and the problem is now I've done over 1,000 of these operations. I still struggle sometimes getting the portals right and making it work. You can break the wires in the joint, which makes it fun. It's usually last case on a Friday. And in the UK, getting remuneration for hip arthroscopy is going to become increasingly a difficult problem. It's been labelled a low priority procedure. In terms of learning curve, it's about 30 cases, and I suspect we need to go on and continue learning. Now, Vikas, I was going to go on and talk about our outcomes, but I suspect in the interest of time, do you want me to stop or do you want me to carry on?
A couple of slides would be good.
Just to give you an idea, so in terms of the CAMs, what you can and can't achieve, we've got minimum 2-year follow-up now on 150 patients. The inclusions are what you've heard already today. These are patients without osteoarthritis who have MRI scan and CT based diagnoses. We exclude anyone with tonus grade 2 and above. Standard technique that you've seen, so I'm going to basically skip through it all in terms of what we do, and happy to discuss it with you. But the key is we've stratified these patients very, very carefully. These are the highly selected patients we expect to do well, who had big CAM lesions, but still about 68% of them needed some form of labral resection because we couldn't repair the labrum. And 86, more than half, had grade 4 chondral damage by the time they got to us for their CAM resection. So we're getting these patients too late, even in a unit that gets referred a lot of them. You get an improved range of motion in almost all of them. You used to get very high patient satisfaction. It's very interesting because these patients want to typically get back to sport, and even if they still have some pain, they get back to their sport, which is what they're really after. Non-arthritic hip score improves with about 75% excellent. They get their UCLA score up, but there's a real dilemma here, because once you've seen a full thickness chondral defect, I think there are ethical issues about encouraging someone to get back to impact sport, which you really need to think about. 6 deteriorate, and there is, I think, a problem in hip arthroscopy. You're all enthusiasts because you're in this room, but there are some patients, I believe, in whom I've precipitated a problem by operating, and we really need to be able to pick out those patients very, very carefully, and some don't get better. So I think over time I'll conclude by saying it's a great operation, it's getting better and we're understanding it more. There's no doubt there's a learning curve, so you need to be with someone who's done a lot of them, and we're still not quite there in terms of identifying exactly which patients benefit. Thank you very much.
Thank you very much, Paris. So once we've done